Thank you very much for the invitation. I'll talk a little bit about qSOFA and try and sort of clarify some of the confusion. So what use does it have? No declarations of interest. Although I was involved with the Sepsis 3 guidelines that came out 2 years ago, and what were the aims and the intentions of these new definitions? To offer new definitions for sepsis, septic shock that updated our current understanding of pathophysiology. To offer, because the previous definitions hadn't specified what they meant by severe sepsis and shock. So different people did different things, so we wanted specific criteria to offer more consistency for epidemiology, coding, and research. And completely separately, to offer a quick bedside tool, the qSOFA, to identify patients with suspected infection who are likely to have organ dysfunction at a quick bedside assessment, who are likely to do badly. And clearly this can't be the final word. We wanted this to generate thought, discussion, debate, future studies, so Sepsis 4 will be hopefully an improvement. And yeah, has it made impact? I think it has. People are talking about it, which is really good. So the paper's had, this is downloaded a few days ago, over 2 million views, over 1,000 citations, and an altmetric score, which shows how much interest there is in the paper. It was the 19th most discussed paper in the scientific literature in 2016. So we're achieving the aim of people knowing about it, talking about it, discussing it. qSOFA. So this is a rapid bedside risk stratification tool to identify those patients who are thought to have infection, who are likely to do badly, either end up dying or end up going to ICU for 3 or more days. And there are 3 aspects to it: respiratory rate, altered cognition, so any drop in Glasgow Coma score, or any change from their normal baseline, and a systolic blood pressure of 100 or below. So just 3 simple criteria that can be done in 2 minutes at the bedside. It was never intended to be a screening tool. And I think a huge amount of confusion has come out of this. It simply identifies patients at risk of doing badly. I was talking yesterday about lactate. It's the same thing. A high lactate tells you this patient's at much higher risk of doing badly, but still patients with a normal lactate are at risk of doing badly. Not as many, but still a significant number. So it's just focusing in terms of specificity rather than sensitivity. Just a few quick slides to describe how it was derived. So Chris Seymour, who's in Pittsburgh, did most of the hard work on this, and he initially looked at the Pittsburgh database, which is a whole pan-hospital database, and then developed the criteria and then validated them against 4 separate databases, 2 large US hospital databases. You can see here millions of patients, and a German from Jena, from Frank Brunkhorst, and an emergency service database. This is just the Pittsburgh one. You can see 12 hospitals, 1.4 million patient encounters, and he basically pulled out patients who had had blood cultures taken and then antibiotics started, not as prophylaxis. So the doctor was worried that the patient may have infection. We don't know if they absolutely did have infection or not, but the clinician was worried enough to take cultures and start an antibiotic. And there were 11% of the whole population fulfilled that criteria. The majority outside the intensive care unit, half emergency department, half on the wards. And of these 148,000 patients, 4% ended up dying. So the vast majority of patients with infection in hospitals do not end up dying. And I've got similar UK data that shows exactly the same. In the UK, it's 2.5%. So it puts it into perspective. Not everyone with a temperature will drop dead of sepsis. He looked at about 28 variables that are routinely measured in patients, either in the ICU or the ward, and saw which were abnormal, and basically using sort of Bayesian statistics, regression analyses, etc., he found a Glasgow coma scale drop, a respiratory rate, and where is it? Oh, come up, here we are. A blood pressure were the three variables that were the best at detecting patients who were likely to do badly. And this is outside the ICU, this is in the Pittsburgh population. Basically, you can see there the mortality rate goes up with more SIRS criteria and with more of these qSOFA criteria. However, 24% of these patients with infection, suspected infection, had 2 or 3 qSOFA points, and they accounted for 70% of the patients that were likely to do badly. For the SIRS population, you needed to look at twice as many patients. And as he analyzed it, if you compare 2 or more SIRS against 0 or 1 SIRS criteria, there was a 2 to 7-fold increase in the rate of in-hospital mortality, whereas with qSOFA, it could go up to as high as an 80-fold change compared to 0 or 1 criteria. However, there have been multiple papers examining its role as a screening tool, and it can't be. It was never intended to be. They clearly didn't read the original paper. And so you've got lots and lots of papers showing, yes, it's not very sensitive, we know that, but it is pretty specific, so it can't be a screening tool. As we wrote in the original sort of main paper, it can be rapidly scored at the bedside without the need to take any blood tests, unlike, obviously, SIRS. And it's hoped that it will help identify quickly those people who are at particular risk. And if they haven't already had the blood test, that might prompt the clinician to think, should I be doing the blood test to see, do they have organ dysfunction, etc. And as we wrote, it will primarily aid management, but also enable SOFA scoring to say, do they definitively have sepsis by the new criteria? And again, it's not meant to replace SIRS. SIRS is useful for looking at infection, temperature, white count, etc. So it's not meant to be an either-or. You're meant to look at all of these criteria together. Again, we made the point that just because the patient doesn't have 2 or more of these criteria, it shouldn't lead to either not investigating these patients or not treating them, or any delay in any other aspect of care deemed necessary by the clinician. Just like I mentioned earlier with lactate. Just because the patient's got a normal lactate, if you're worried about the patient, treat them. Don't assume, oh, the lactate's normal, qSOFA's normal, I don't need to do nothing. Again, we made the point it was derived retrospectively from databases, looking at different time windows. So it could be a useful tool, maybe even more so for those outside the intensive care unit rather than inside, because it just relies on a bedside clinical examination that can be done repeatedly. However, we strongly encouraged prospective validation to see how robust it would be. The data mainly came from US patients. Does it work in France, in the UK, in the middle of Africa? And there are some studies which, again, make this point quite neatly. This is a study looking at an American database of patients with infection, 2,500 events, and emphasizing the point I made. Many of them had SIRS, fewer had the SOFA criteria, even fewer had the qSOFA criteria. So these patients basically identified, if my pointer's dying on me, but you can see the, oh, sorry, do you have another pointer? No, you don't have a, Oh, it's come back. Sorry, thank you. So you can see here that the mortality was much higher in the smaller number of patients identified by 2 or more qSOFA. And I think the authors correctly said that, yes, they're looking at different things, different populations. And the qSOFA will identify patients who are at elevated risk of poor outcomes that could be used in future epidemiology studies and studies of patients with infection. This came from France, as well as Spain, Belgium, Switzerland, 30 emergency departments. A prospective study, which is the best sort of study to do rather than a rehash of big data. Over 1,000 patients screened, nearly 900 analysed, overall mortality 8%. And again, the point I made earlier, they had 3 times as many patients with 2 or more SIRS as 2 or more qSOFA. But the qSOFA was much better in picking out those patients who would end up dying. 24% with 2 or 3 qSOFA versus 3% if you didn't. For SOFA, 18% versus 3. SIRS, 11% versus 2%. Severe sepsis, the old way of doing it, 20 versus 6. And the authors concluded that, yep, this does seem to be a useful tool. Sorry, the battery's gone on the pointer. Okay, as I mentioned, there's a lot of confusion. I would argue people haven't read the paper, but hey, that's my interpretation. There's a systematic review of all of these screening studies that's coming out in Annals of Internal Medicine in a few weeks' time, and I was asked to write an editorial. I did so with Manu Shankahari, who was another of the Sepsis 3 task force, and you see we entitled it qSOFA, Q Confusion. And again, emphasizing it's not a screening tool. We don't know yet. It needs to be determined how useful it will be as a clinical decision tool. Clearly, you can do it repeatedly. You don't need to do repeated lab tests like you would do for SIRS. And obviously, the more data you collect... Oh, can you go back one? Sorry, thank you. The more data you collect, the more accurate it will be. So in the UK, we have something called the NEWS score, the National Early Warning Score, which now is going across the whole country from GPs, nursing homes, paramedics, all the way through to hospitals. And so these are regularly scored. I'll show you it in a minute. So it's 7 bedside variables, 3 of which actually are the qSOFA variables. And therefore, because you're recording 7 things rather than 3, it must be more accurate, yet there's a greater workload. In this editorial, we've gone through the different uses of a tool, screening, diagnostic, severity scoring, for clinical decision-making, and we've tried to clarify the misinterpretations, but I've only got 1.5 minutes to do it, so this is a sampler of what you can read if you wish from next week onwards. This is the National Early Warning Score. These are the 3 qSOFA criteria. So you'll score a minimum of 4, if not 5, if you have 2 criteria. And in the UK, if you have a total score of 5 or more, the nurse has to call the doctor. Or if they're worried about the patient, they can call them earlier, but it has to be called with a score of 5 or more, and they have to increase the frequency of observations. This came from Cherpek and colleagues. Sorry, it didn't, the animation didn't work. So this is a guy in Chicago. They looked at their database, and with a new score of 8, if you remember, UK we used 5 or above, they had a cutoff of 8. Not surprisingly, scoring more things gives you a better discrimination for predicting in-hospital mortality. So NEWS and MEWS, the modified early warning score, did better than qSOFA, which did better than SIRS. However, if you looked at a new score of just 5, again, it was better than qSOFA, but not a huge amount different. So in summary, 17 seconds to go. qSOFA is a quick, simple, repeatable bedside tool to identify high-risk patients. Haven't got time to show you the data now. It's in Chris Seymour's paper. But prognostically, 2 or more qSOFA was equivalent to actually measuring, taking a blood sample to measure lactate. Oh, gosh. Can you go back? Back one. Back one. Back one. Back one. No, you can't do it. Okay, so that was a subsidiary slide. So very briefly, it needs prospective validation. It needs looking into, but it sort of be aware of what it is rather than what it isn't. Thank you very much for listening.